I'm in my hotel room here in Pensacola, Florida at the Hilton, and I had a presentation recently with the Louisiana Dental Association. Before going out to the pool and enjoy like the rest of the normal people, I figured from the balcony of my hotel room here, I'll do one quick Q&A that had come up from our online group, and I thought it was an interesting question, and I figured I'll share it with you guys with my answer, or at least an attempt at an answer to this question that had come up. So from this gentleman here on the Dental and Implant Care Center, say thank you for the time you spent educating us. I did use the Scout files with my ESX. It really helped me, thanks a lot. That's actually a great combination of using the ESX files with the Scout files. But whatever I do to get the final RCT to look like an endodontist root canal, how can I make it look like that? Do they use a higher taper files? Is a higher taper and more colorful than mine? I use BC Sealer as well, and I want to use what microscope do you recommend? Thank you. So, well, as far as first, the last question is what microscope do I recommend? There are many scopes out there, and all of which are good in their own way. Depends on, first of all, on your budget, and then depends on your priorities. If the optics is more important, if the arm is more important, if the service is more important, all of those are valid concerns, and in terms of what you want to have, I will probably say you need to find out what kind of scope is available in your local area and which scopes are best serviced in your local area, so you can have that ability to get the best scope that matches your specific geographical area. There's no universal answer as far as that is concerned. So the other question, however, how can we make our root canals look more like an endodontist, begs the question of what does an endodontist root canal look like? And also the more important question, one level up, as to why should root canals look any particular way? After all, what we try to do when we do root canal therapy is not to create looks on the x-ray, or at least ideally we don't try to do that. That's not the aim of root canal therapy. In fact, the most important aspect of root canal therapy is the radiolucent part. It is the getting rid of the microbes and antigens inside the root canal before we fill the root canal with the obturation material. It's very unfortunate, but we have put so much emphasis in this profession, starting from the 1960s with the filling of the root canals, with Dr. Schilder's article that created this emphasis on how root canals should look. And in a sense, in my opinion at least, speaking of this philosophically, that has created a little bit of an impediment for the progress in this field, because perhaps the things that are going to help us achieve better success rates are not necessarily going to make a root canal look a certain way. Because, as I mentioned, if there was a way that we could get rid of all these microbes inside the root canal, we wouldn't even have to use any kind of a filling material. If there was a way we could gamma radiate a tooth completely and sterilize it, there would be no need for obturation or even instrumentation. Unfortunately, that's not possible at the present time. Therefore, we use these tools and these means and methods and materials in order to clean, disinfect, and then obturate and fill root canals. But that is, the priority is not how things look on the x-ray. So instead of thinking of how we should make a root canal look better, because that leads to manufacturers pumping more and more radiopacifying agents into their filling materials, into their gutta percha and into their sealers, which actually achieves nothing at all in terms of your success rate, but it somehow psychologically works on making you think that you've done a good job by making cases and x-rays appear more radiopaque. Again, zero correlation with your success rate based on how much barium sulfate or zirconia you have in your cement. What we need to do is we need to keep focusing on achieving great results for our patients by having a patient-based outcome in which we are getting rid of the microbes and creating happy and healthy patients. That has been something that I always talk about. In fact, I did mention and went into that during my presentation here while visiting Pensacola for the Louisiana Dental Association presentation that I gave yesterday. So I just want to correct the question a little bit, in the sense that our goal should not be to have root canals that look a certain way, but how can we achieve the main objectives of root canal therapy? So probably the best approach would be to say, how can we achieve the objectives that endodontists are trying to achieve? And that is not to create a look, but rather primarily to find all the root canal, because the root canals that are present in a given tooth, because clearly the number one source of root canal failures is in fact missed canals. It isn't cracked or things like that we've been taught by many people on the circuit. It is in fact missed canals that causes the most endodontic failures, missed canal and anatomy. The question here is, after finding those orifices of the canals, how can we work our way down to the apices of these teeth, and then making sure that we stay true to the full depth, or rather the full length of the root canal space, not being under instrumenting, creating problems on the way down with ledging or transportation or perforations, nor over-instrumenting through perforating the apex, and all of that is a byproduct of sloppy length management during root canal therapy. And then once that very most important part is done of getting down to the end of the root, achieving length, maintaining length, and then enlarging the apical diameter and to an adequate anatomical size in which we get rid of the biofilm and the microbes through irrigation and this biomechanical instrumentation, then how do we obturate the root canal from that point on? Now, the look that you achieve from what we see on the x-ray is primarily a function of the radiopacifiers and the filling material. But as I mentioned, the important part is the parts that precede that. And so we need to keep on focusing on that again. How can we find all the canals? CBCT and a good understanding of the normal anatomical distribution of the number of canals and their locations in a given population and a given tooth is very important. And then working your way down the canal by having root canal instruments that are flexible enough, and then having enough information and knowledge about how do we manage the debris on the way down, and how do we not push debris down apically, and how do we not get lead. And then how do we achieve working length, having apex locators and confirming radiographs. And then finally, how do we achieve and find that right gauging of the right apical diameter for a given tooth? How do we irrigate and disinfect this space? And then lastly, how do we fill it in an optimal manner? In terms of the canal, you said it talks about the size of the preparation. That really is immaterial. Frankly, we used to have excellent success rates with O2 taper hand instruments, with the Washington study has showed us that. And then when we went to a little bit more efficient method of instrumentation using the O6 and the O4 taper night-eye rotary instruments, and I find that anywhere from the O2 to O4 to the O6 taper, as long as the O6 remains on the smaller side of, no more than, let's say, a 30 O6, so you don't end up removing too much coronal dentin unnecessarily, that's adequate size. So once again, just to sum up the whole thing, I think to make your cases look more like an endodontist, you have to think of those objective priorities that are the most important part of the case. And we have to de-emphasize as much what we see nowadays, which is a new brand of Instagram endodontics that has come out, in which people keep showing off their cases on the social media and thinking that x-ray is really what it's all about. The x-ray is not what it's all about, and it's ultimately the goal is to have happy and healthy patients, which would be independent of what we see on the x-ray. You could have a very angry and patient still in pain, whereas the x-ray could look very good, and that's an important consideration to have. All right, so with this little bit of a long diatribe into a philosophy of practice and so on, I just want to hear your opinion also about this concept of how can we make cases look more like an endodontist. If you disagree with what I said in terms of the priorities, which is the, those things that come before how things look, all of those aspects of the tooth. And after that, I'm gonna head down now to the pool and enjoy myself a little bit, and I'll see you guys in the next video. Until then, let's save some teeth.